Good afternoon, everyone. I'm here speaking on a comparative study of tear film changes with terrorism and after terrorism excision with conjunctival limbal autograft. I have no financial disclosure. Terrorism is the most common ocular surface disorder and has been frequently associated with dry eye disease. Global prevalence is 2.3 to 21.3% and reaching higher number in tropical region. The purpose of this study to evaluate tear film and meibomian gland functional changes in patients with terrorism and after terrorism excision with conjunctival limbal autograft. As we know, terrorism can cause symptoms of discomfort, corneal irregularities, induce astigmatism, tear film disturbance, thus compromising visual acuity and patient's quality of the life, as terrorism destroy superficial layer of the stroma and Bowman's membrane and also associated with meibomian gland changes and implicate in meibomian gland dysfunction. Here we adopted terrorism excision with conjunctival limbal autograft, which was suture and glue-free autologous graft. In this study, this is a interventional comparative study with a population of 55 patients with unilateral grade 2 terrorism. Ethical clearance was taken and demographic data were recorded. It was 1 year study duration and it was conducted at the tertiary healthcare center. The tear film changes and dry eye disease assessment was done of all the subjects before and after 1 and 3rd month of the surgical intervention by Ocular Surface Disease Index questionnaire, Schirmer's 1 test, TBUT, TMH scoring, and meibomian gland expressibility were recorded. Exclusion criteria were patient with any corneal disease, scar, contact lens user, cicatricial ocular surface disease, ocular allergy, trauma, infectious were excluded. These are then tear film measurement and other parameters were compared before and after terrorism excision with conjunctival limbal autograft. And results, age distribution of terrorism was maximum 30 to 40 year age, 40 to 50 year age with male preponderance. Schirmer's 1 test value were significant low, less than 10 mm in patient with terrorism compared to the terrorism excision with conjunctival limbal autograft. Same TBUT were less in terrorism patient than post-op patients, and TMH value were also significantly low in pre-op than post-op. The mean value of meibomian scores was statistically significant, and on the discussion part, the study was also, our finding were also supported by other study, as Kim et al. Found TBUT significant improve after conjunctival limbal autograft, and APEC et al. Also compared terrorism with terrorism healthy control, and he concluded terrorism is associated with tear film instability and dry eye disease. Shai et al. Also found a TBUT significant improve in conjunctival autograft. He compared conjunctival autograft versus conjunctival autograft with amniotic membrane, and he found significant improvement in both groups. And same Shrestha et al. Who studied on the bare sclera, he showed deterioration in the tear film stability and its secretion, and an increase in the prevalence of the dry eye disease if we were doing without graft. So limitation of our study were the comparison with other technique. We have not compared the tear film changes after terrorism excision with the CLAG, and evolution of tear film cytokines and growth factor were not recorded, and correlation for long-term clinical outcome were missed. So overall, future research in these area can provide valuable information on the mechanism and clinical implication of tear film changes after terrorism excision with CLAG, and can guide clinician in selecting the most appropriate treatment option for their study. So I concluded that terrorism has a close relationship with tear film in stability and meibomian action, and tear films improve terrorism excision with CLAG. Thank you.
Thank you,
These are
Dr. Vidhya.
references.
Very nicely presented, very nicely done study. Dr. Vidhya, what would be your comment on the clinical significance of the study? How badly were the patients affected at the beginning, and how much relief did they get?
It's showing as terrorism is there is association with a dry eye disease. So if we excise it on the time, we can improve ocular surface health.
Were the patients symptomatic before surgery? How much? And does that come to be clinically significant?
Yes, that's why this study shows that even patient is, if not complaining, even though we should consider for the surgical excision in the
If the patient is not complaining, how does it matter?
for actually if we see tear film changes, as we have seen this in this study, so there are ocular surface health problem with pterisium, which will ultimately finally this is the one of the cause of the after pterisium excision of the recurrence of pterisium, and visual acuity also disturbed. So I think I prefer to excise on the time with graft.
Excision of pterygium is well taken.
Yeah.
The justification for the excision of pterygium, give me a good proof that yes, it is justified to excise a pterygium in order to treat dry eye disease. How can we make if a patient is asymptomatic, how can we make that patient feel better? It comes down to that principle of treatment of a patient, right?
So we can assess tear film changes, maybe gland dysfunction, and if is it there, then we can advise.
So I would say we start off with discomfort index and quality of life.
Yes.